Hello, everyone. I'm Cinda Rushton. I'm the co-chair of the Johns Hopkins Hospital Ethics Committee and Consultation Service and faculty in the Berman Institute of Bioethics in the School of Nursing. So welcome to our Ethics for Lunch for March. We have no disclosures to share today from our panelists, and we are really pleased for you to be a part of this conversation about balancing patient experience and staff safety. In order for you to verify your attendance today, you need to text the code 38116 to the number here 443-541-5052. So please be sure to do that so that we can keep track of who has been with us, and we really appreciate your participation today in this important conversation. We have a fabulous panel today to talk about this very challenging and important issue. To get us started, I wanted to start by really giving a little bit of context for our conversation today. And before we do that, I'd like to be able to start the slide on the beginning and to have our panelists introduce themselves. So I introduced myself. Stephanie, would you like to introduce yourself?
Sure. Hi, everyone. My name is Stephanie Gray. I have been here at Johns Hopkins for about 17 years. I'm currently a lead clinical nurse, but right now I'm the interim nurse manager of the Weinberg ICU.
Wonderful. Thank you, Stephanie, for being with us. Meg Garrett, well known to everyone here in our Hopkins community.
Hi, Meg Garrett, member of the Ethics Committee, retired Vice President of Risk Management and Chief Legal Counsel for the Johns Hopkins Health System. And I'm currently the past president, the immediate past president of the American Society of Healthcare Risk Management. And definitely a very ripe topic that certainly we at Hopkins have been involved in for a long time, and nationally definitely on the top of the list. Thank you for attending today. Sorry, I'm down here in Annapolis on the waterfront, so you might hear a boat go by. I will mute.
Thank you, Meg. And Lisa.
Hi, I'm Lisa Allen. I'm the Chief Patient Experience Officer for Johns Hopkins Medicine and also run patient experience at the Johns Hopkins Hospital. I've been here for about 7.5 years, and I've already told Meg that I'm jealous that she's on the water today. So we'll get some of the sound of the wind and the boats.
Yeah, exactly. So welcome to our panelists. I think it would be safe to say that we are in some challenging times. And one of the things that we are all aware of, and I think is the reason why we wanted to talk about this issue, is the increase in violence in the workplace. And the Bureau of Labor Statistics verifies this assumption. And you can see here that over 20,000 workers in private industry experienced trauma from non-fatal workplace violence in 2019. And I'll share some statistics in a moment that indicate that these statistics may in fact be worse. In those individuals who experienced workplace violence, 68% were female, 65% were aged 25 to 54. And what's really alarming here is 70% of those 20,000 workers were in healthcare or social assistance industries. And in response to those, about 21% required 31 or more days away from work to recover, and about 20% had at least 3 to 5 days away from work. So what these statistics tell us is that this is a problem that has been present prior to the pandemic. And the Joint Commission has actually taken some steps to try to address some of these issues. And when we talk about the issue of workplace violence, this is the definition that the Joint Commission uses. An act or threat occurring at the workplace that include any of the following: verbal, nonverbal, written, or physical aggression, threatening, intimidating, harassing, or humiliating words or actions, bullying, sabotage, sexual harassment, physical assaults, or other behaviors of concern that involve staff, licensed practitioners, patients, or visitors. So if you think about this definition, there are many occasions where what is identified as workplace violence incidents are probably occurring. What's also clear in a profession like nursing, over 4 million in this country, given the statistics that 68% of people who were the victims of workplace violence were female. The statistics prior to the pandemic were concerning. 21% of registered nurses and nursing students reported being physically assaulted, or half of them reported verbal abuse in a 12-month period. This reality has intensified during the pandemic, and in a more recent survey, 44% of nurses reported physical violence and over 2/3 verbal abuse. The other thing that we know is that these instances are very clearly underreported. And even though efforts have been undertaken to increase reporting options for nurses, in this most recent survey involving nurses caring for patients during COVID, 1 in 10 reported that it was more difficult during the pandemic to report these instances than before. So when you think about this issue, the cost of workplace violence is significant, both in terms of treatment for the injuries, both emotional and physical, as well as lost wages. We also know that it contributes to caregiver fatigue, personal injury, stress, and is related to increased medication errors and patient infections. And also that these circumstances and stress contribute to staff turnover. So I'm going to ask Stephanie to sort of start our conversation today. Stephanie has been a nurse, as she mentioned, for many years. And we asked her to share a case that illustrates some of the issues that many nurses are experiencing of violence in the workplace. So Stephanie, I'm going to turn it to you.
Thank you. Okay, so I'll just give you a quick synopsis of the story, and then I can obviously go into details and answer some questions. So we had a patient in the Weinberg ICU who was a 54-year-old man. He was admitted with COVID complications. He suffered multiple arrests in the hospital, then required resuscitation, and then that's when he came to us in the ICU. He experienced a traumatic brain injury due to this, which caused extreme agitation, violent behaviors. He was very impulsive. Despite his lack of capacity, staff were very concerned for their safety. Many of them were kicked, they were hit when the patient was very agitated and violent. Staff were also verbally abused by the patient and his family, including yelling. There was threats of reporting the staff to authorities. As this patient's violent behaviors came worse, staff did not feel comfortable caring for him and reported being distressed and fearful at work. Staff contacted the RISE team. They placed multiple heroes almost daily. Safety measures were put into place due to that. So when I got involved really was more so a couple months after the patient was here, I'm hearing more and more complaints of feeling afraid to take care of the patient. So then I'm getting concerned because now staff are afraid to go in the room. We had a sitter with the patient at all times. So there was a sitter in there, but because the patient was here very long term, the sitters were also getting afraid for themselves, as well as the verbal abuse from the family. So that was like twofold. So they were getting, I would think, workplace violence from two different ways, physical and emotional on top of it. So that's when I got concerned, reached out to my directors and tried to come up with a plan to try to protect my staff. So at this point is when we got security involved. So now we have a security guard in the room. So mainly that was there to protect my staff, protect the sitters, protect the nurses, so that when he does get violent or did get violent, they could be protected. Not the family obviously saw this as a different way, but really my goal was to protect the staff and to help them feel safe going in the room, knowing that they had support in the room. The other thing that we did to help with the staff was to do a rotating list so that staff weren't in there consistently, because it's hard as a charge nurse to know the last time a nurse was in a room, and they were all getting so emotionally and physically exhausted being in there that we had to come up with some sort of plan so that they felt relief. So we started a list of our staff as well as travelers, SSU staff that were shared with us, to where we routinely were going through the list so that staff weren't in there more times than necessary. So everybody had equal amount of time in the room. So it just gave more support to them to feel like we heard them, we wanted to protect them, and to really help them through this difficult situation.
Your story is not an uncommon one. And this has been a topic that I know the whole health system has been working on now for a number of years. And one of the ethical challenges is, how do we, on the one hand, create an environment where staff feel safe, but also try to honor our primary commitment to our patients. So I wonder, Lisa, if you could just talk a little bit about this tension, that is sort of inherent in a case like this, of how do we think about that balance?
Yeah, so it's interesting when we were talking about this
Lisa, you want
case.
to unmute yourself?
Oh, am I unmuted? Yeah. Okay, good. So, I would say that when we were talking about this case, we hear about it. I also am responsible for patient relations at the Johns Hopkins Hospital under Britt Bradley. And we hear about these kinds of cases. And I've had people come to me and say things like, well, we want to make sure that we're patient and family-centered care, or that, we don't want to get a bad HCAP score. And my philosophy is that it's about safety first. It's about doing the right clinical care first. There will always be patients and families that will be unhappy with how we've handled something, but they are a minority of families that we serve. And so thinking about what kind of resources do we have? And, I know that Stephanie ended up calling security and things escalated, but there are things such as calling security, calling patient relations, working through de-escalation. And ultimately, if we are feeling that our families are creating more stress, we need to have conversations and behavioral contracts with them and to manage them. So, I look at our data, and our data shows that we have 84% of our families gave us, or patients and families gave us, a 9 or a 10 on their overall rating of care. That puts us in the 97th percentile nationally. So the majority of people are saying really good things about us. And it's less than 2% of patients and families who give us a never. And we're willing to deal with that, because we do believe that it is creating a safe environment where we have partnership, and that it's a respectful kind of an environment. And I just want to read one comment. This patient said, "This was the best hospital experience in my history, including at Johns Hopkins. The nurses were stretched to the limit, yet were always collected, calm, ready to explain and advise me of medicine, hospital procedures, and monitoring my vitals. Having been admitted with breathing issues, With the rapid turnover of patients, the COVID pandemic creating shortages, the high burden of managing technology while fully engaged as a hands-on nurse or technician with the patient again was above and beyond. I saw this having worked in healthcare and medicine all of my career. So it says, even when I was a surgical patient that didn't meet the high standards that they felt on Nelson 6, which is a medicine unit. Even if you have experience in medicine, when you are sick or quite ill or have trauma, all that goes out the window and you look to staff for guidance and trust. It's always fun to watch until it's you. I appreciate the nurses showing each other respect and supporting each other in an exceptionally fast-paced medical floor. And I found many, many comments like this. And really it is that partnership, which is what we're looking for. But when it fails, then I think we have to use the resources we have.
So Lisa, that's it. It's kind of natural, right? That we remember the hard cases. And the truth is that they actually are a minority, but when you're in it, as Stephanie, sort of pointed out, it's hard to make sense out of. And what I hear you saying is, when we think about how to balance our obligations, we are very patient-centered. Most of us came into this work because of our patients. And so when we're in a situation where we feel like we have to choose between our own well-being and that of the patient, it creates a lot of distress for us. And I think what you're suggesting here is that it's not a one-way relationship, that it's really about a balance and making sure that everyone is respected in the process.
Absolutely. Our patients' rights and responsibilities has a responsibility section to it. And part of it is being respectful in a healthcare setting. And I think when that goes out the window, we really have to look at these other resources. I mean, our staff deserves a safe place to work and to be treated with respect, just as our patients and families do.
Thank you. Thank you. So Meg, you have been involved in trying to help staff and patients navigate these tensions. And I think sometimes when people are feeling the distress, like Stephanie described, they'll call legal, they may call ethics as well. Tell us a little bit about what the legal landscape is in the space around violence against healthcare workers.
So I was going to thank you, Cinda. I was going to add to what Lisa was saying, security and patient relations. Definitely risk management is 24/7/legal. And we're always, the folks, I can say they are always ready and available to, sorry, my allergies sitting out here on the water are making me cry a little bit. But anyhow, before I get into the true legal landscape, I wanted it from a risk management standpoint, because the American Hospital Association has taken this quite seriously as well. And we did a study as to kind of why we're seeing an increase and so on. Certainly COVID is in there. But I think the number one of the main reasons is the prevalence of guns in our families, in Baltimore, in our area and so on. And certainly is similar to the way it is in other cities around the country. Some of you may have been at Hopkins in 2010, and we had been preaching probably for 15 years about workplace violence. And I had spoken the night before, this was in September 2010, at the American Society of Nurse Legal Consultants. And somebody said to me, "What keeps you awake at night? What do you worry about?" And I said, I really worry about workplace violence. We had just had situations in, all our college campuses and so on. And the very next day I was in a meeting, and it was the day that we had an angry family member shoot one of our physicians and end up killing himself and his mother, who was the patient. And, when I interviewed people about the situation, everybody said, I expected him to go postal. And I think one of the big things that's critical for us is making sure that we speak up when things are, nurses and providers, everybody kind of gets that sixth sense. Use your gut, contact, folks and so on. Somebody actually said, that black bag that he had, somebody said he probably has a gun in there. And sure enough, that's where the gun was. Another reason in some of the emergency rooms, and Hopkins is not foreign to this, is the increase in criminals being held, bringing them to the emergency room. And then we end up with gang members coming in and that type of thing. Haven't had it as much at Hopkins, but we certainly have had it at Howard County and other places. Another reason in our survey was the increased number of acute and chronic psych patients. We just don't have enough mental health providers to go around. Certainly the availability and drug-seeking behavior, which cut down dramatically during the first period of time with COVID, but definitely came back on the rise again now that we're in a different position. The Unrest, one of the challenges, and that I've certainly heard from nurses when I've done risk rounds, was the unrestricted movement of the public in the clinics and around the hospital. And I know, Lisa, you told me the other day of something new that's going to be occurring at Hopkins through a lot of studies that have been done about safety at Hopkins. Like I said earlier, the increased presence of gang members in the community, as well as, the trauma patient coming in, distraught family members. I know we had a lot of anger from family members when they weren't allowed to come to the hospital during COVID. Staff shortages. You don't have the time to spend with everybody that you may have had in the past. We have workers in remote locations. That also is an area that not maybe as much at Hopkins, but certainly at other inner city hospitals. I know downtown Philadelphia has had a number of issues with some of the remote clinics. The lack of training and recognition, which I think Hopkins is doing a really good job of teaching about de-escalation. And another area that's been a hotbed is parking garages. We certainly had issues there, and that's why we have security constantly going through the area. So from a legal standpoint, after we had the situation with the shooting in 2010, a number of individuals, Hopkins legal department and others, went to Annapolis, which is where I am today, to argue that any healthcare provider who is harmed in the workplace, it should be a felony rather than a misdemeanor. Many years we've tried to get this law enacted. There are, I think, 20 some states right now that the law is that it is a felony. If you're a firefighter or a policeman or a paramedic, any injury to them by violence is considered a felony, but we have tried very unsuccessfully. And I know it's been in the legislature this year again, and I haven't walked in up the hill here, but I have a sad feeling that it probably will not pass. So one of the things that, from a legal standpoint, we strongly encourage staff to file criminal complaints against patients. Nurses are like, no, I can't sue a patient. Well, we can, but one of the challenges with that is that in the criminal world, you have to be able to identify the injured person, and that injured person ends up testifying or, whatever from a criminal standpoint. The sad part is that sometimes you have to give up your address. And people say to me, well, why can't it just be the Johns Hopkins Hospital versus, Tommy Smith who hit me or scared me or did, whatever. And the legal term, assault is the fear that somebody's going to hurt you. Battery is the actual touching. But, somebody who's, got a communicable disease who's trying to spit on you and so on, I certainly argue that that's an assault. We will help anybody who wants to file charges. I mean, the legal department goes with you to the police and/or security goes with you to the police department. I've certainly gone to court with providers where we end up with a trial in a criminal case. And many times, we actually do win on those cases. But, people are reluctant to, bring charges against someone because they may be part of a gang and, that type of thing. Security, we certainly get restraining orders from individuals so that they can't come, to your home and so on. But, it does still put people at edge. In the first, I guess I was at Hopkins about 10 years. And, I was working on a dialysis case where this patient was threatening all my dialysis nurses and figured out where their kids went to daycare and everything else. Just a very angry person who, ended up with dialysis because of some not so good behaviors. And he was always threatening. So, we threatened to fire him from dialysis, which the law at that time said that they had every legal right to, and we couldn't fire a patient. We went all the way up through the Kidney Commission and actually got the law changed. So one day I was at Bayview, a meeting with this patient's lawyer and the patient. And when I came out and started my car, I tried driving it and the lug nuts came off and the car ended up on the ground, kind of thing. So I've personally felt it. I had small children. I was quite anxious about the possibility. He certainly had my address. He had a whole gang behind him. And thereafter my car was always in kind of protective custody. But I actually filed criminal charges against him. And I guess the sad or interesting issue was I was going to court against him on a Monday morning, and on Sunday, he sadly passed away from his kidney disease. But, it took me a while to do it. But, at times there have to be repercussions for people's behavior. And so, from a legal standpoint, there certainly is a way, but I prefer to get people involved as early as possible, and getting security there to assist, certainly keeping families out, raising the flag when you have that gut feeling. Please bring it up to the folks. I've said enough for the moment. Thank you.
Thank you, Meg. I think Meg's comments really point out the complexity of this particular issue, and that it's not an easy balance, because on the one hand, as clinicians, we, if you think about the case that Stephanie shared with us, this is a person who has a traumatic brain injury. And the behaviors, even though the person lacked capacity, have a huge impact on the people who are trying to provide care. And then when you add to it the complexity of family behaviors, I think a lot of times nurses and other clinicians, will overlook and normalize behaviors that maybe should not be normalized in the circumstance. So I wanted to share some work that I've had the wonderful opportunity to be involved with the Barrel Institute, which is really focused on patient experience, of trying to figure out if there was a way that we could begin to create an ethical framework for how to think about this balance. And so in the process of that work, we came up with these 7 ethical precepts. And these can be used as sort of touchstones as we're trying to think about how to respond to these situations where there really is a conflict in terms of our obligations for patient care, but also for our own safety. And so I just wanted to share these 7 ethical precepts today as a way to see if they might help us figure out how to balance these competing obligations. So the very first one is that all persons must be safe and secure to live and effectively function. That makes a lot of sense, right? If the patient doesn't feel safe, if the nurse doesn't feel safe, if the other clinicians don't feel safe, then it's really difficult to make a lot of progress. The second one was that everyone, patients, families, and healthcare workers, are treated with respect to honor their inherent dignity as persons. So this is everyone is deserving of respect, no matter who you are or what role you have or what identity you have. Third is that violence and threat toward any persons, and that's patients or family members, their loved ones, or healthcare workers, are ethically impermissible. So we should not be tolerating violence against anyone, whether it is a patient, and we certainly have evidence that patients too have been treated in ways that fall into the category of workplace violence. Fourth was achieving and maintaining a safe and healing environment is a responsibility that is equitably shared among everyone. So our patients, the family members, our healthcare workers and leaders. So we all have a responsibility for creating this environment where people can be safe and respected. Then, as we move forward in the development of policies and practices and decisions, we want to make sure that they are transparent, that they are clearly communicated and consistently applied. And this is an issue of being transparent, both with the people that we're serving, but also within our organization, that people are treated fairly and equitably in the same system. Sixth was the reporting mechanisms that relate to these kinds of instances are confidential, they're timely, responsive, and importantly, they occur without retaliation, discrimination, or blame. And as we all know, there are patterns in our healthcare environment, but also in our society, where there's often some skepticism about what is it that provoked this response and who's responsible for it. And then the last precept was that education and resources to support patients, family members, their loved ones, and healthcare workers are available, accessible, and proactively offered. So what I wanted to pivot toward for just a couple of moments is to get reflections from our panelists about some of the things that actually are working. And Stephanie, I want to start with you. You mentioned that you used support systems. You also used the reporting mechanisms, but just wondering what would you recommend in terms of, is there a process? Are there resources that you found particularly helpful in these challenging cases?
I mean, I feel like it's not a direct path of like, this is what you shouldn't do. So I do feel like that isn't very clear, but for this instance, we did develop one of the ERT response teams. So that I think got everyone involved that needed to be involved for the situation. So ethics, legal. So I feel like we got the feedback from all different sources, which helped guide us in our care. So I feel like that's really what helped us in this particular situation. I don't know if that answered your question.
Yeah, I think one of the things you mentioned that it seems like we wait too long before we ask for help. And, you know, we certainly have that executive response team available. And it seemed like it was really helpful to have everybody talking together to help guide the staff who clearly were really the recipients of some really violent behavior.
But I think as you alluded is that I think as nurses, sometimes we feel like it's just part of the job, and that, you know, especially in this instance, this patient had no control over how he was acting. So I feel like in that sense, you step back as a bedside nurse and say, okay, he doesn't understand. It's okay if he's hitting, kicking, and saying it's okay. And it got to a point where we were like, it's not okay. You should be speaking up. You should be putting in heroes. RISE was contacted, which I think is an amazing resource here at Hopkins. So that helped come talk to staff and helped us come up with a lot of these plans as well. So I think that's an amazing resource that I think could have been used probably earlier in this case. And in most cases, I think they're a valuable resource that I don't think we utilize enough.
So this idea that maybe our threshold for asking for help is not high, you know, that's pretty low, you know, that we might want to recognize those symptoms that are happening of how many people, you know, I can imagine on handoffs talking about what their shift was like and the fear that they experienced. Could we be a little bit more proactive in getting some of these resources that you spoke about? Lisa, I wonder if you have some thoughts about resources that people might not think about, but that could really help in these circumstances.
Yeah, it's interesting because I saw that somebody mentioned social work, and as this was being described, I was thinking about that, and I was thinking about this article I read by this writer, Len Berry, a professor, and he talks about sort of this hostage syndrome that patients often go through, which I think is really interesting. You know, we take away their normal clothes, we put them on our schedule, although we're a little better at Hopkins with that, around eating. We tell them what they can and can't eat. We have people interrupting their sleep, you know, and they're not feeling good. And so really thinking about what are some of the, how can we create a little bit more of maybe a schedule or something that matches their life. But I do think that there are resources, you know, maybe psychiatry. I'm glad that RISE was called in. Patient relations, when families are getting out of control. Chaplain, somebody just brought up, I think, you know, again, thinking about what are the resources that we have. I mean, I understand that the patient had violent behavior based on their brain injury, but what was going on with that family, and how can we pull them out of that situation and have a family meeting so they're not adding to the stress? And I do think that there are resources that we need to think about.
Yeah, we've certainly had instances where involving social work and chaplains has been really, really helpful in what you're talking about and trying to understand what's going on in the family. And there's often a lot of trauma there, distrust. All of those issues may be contributing to the behavior. And yet, you know, if you go back to the ethical precept of everyone being treated with respect, that it is a bi-directional responsibility. And how do we help families to understand what that means, even under stress? You know, that there are sort of acceptable responses, and then there are boundaries that need to be preserved. You know,
I would say absolutely. This is totally bi-directional. And, you know, I've been a care partner and a patient, and I've never understood, you know, how people think that screaming and yelling at staff is going to be helpful for their care. I mean, I find that when you treat people with respect, you get it back. And it is important that patients and families do this, but there are definitely some broken families, and you know, understanding what that stress is. But we do have behavioral contracts, and we do have mechanisms to put into place to say it's just not acceptable. And I do think people need to feel that they can reach out for these resources earlier rather than later.
and I think the other thing that you'd mentioned, Lisa, too, is patient relations and how patient relations might be a resource as well. Can you talk a little bit about that?
Sure. So, I mean, I think people often think of patient relations as, well, once it's hit a grievance, now I have to, you know, deal with it with a letter. But they've been trained in de-escalation techniques. They are happy to facilitate family meetings and to get called in and to talk to staff about approaches. I mean, they're used to dealing, unfortunately, with people who are angry or who are upset about something. And they really work hard on, you know, de-escalating those situations. And sometimes staff just needs a different perspective to come in. And so family meetings are really helpful to have somebody from patient relations in that room. They're there as a patient advocate, but also a staff advocate. So you shouldn't feel like, from a staff perspective, that if they come into the room, you know, oh, you're in trouble, patient relations is involved. We would rather solve it while the patient and family are still in the hospital than wait till they leave. And now it's a formal grievance that we have to deal with. We think we can do a lot more problem solving on the spot.
Great. So Meg, what's your recommendation from the risk and legal point of view?
Well, certainly I agree with everything that's said, but I think the most important thing is early reporting. We have, you know, between the Hero Plus and, you know, other mechanisms to let people know what's going on, because way too often we wait too late. And I think if we get in there, everybody as a group, put all our heads together and come up with a good care plan, it has helped in a number of situations. And I think, you know, having ethics and legal and chaplain and social work, having everybody together, and you know, certainly nursing and the physicians, you know, sometimes don't recognize the severity of the situation because they're usually in there for, you know, 10 minutes or whatever. And they usually come in with a crowd. Nursing, on the other hand, is alone. And, I think that those are all things that need to be considered. I just want to say one other thing. We're talking a lot about patient, on staff and so on. But I want to say that there has been a dramatic increase in staff versus staff, not only, nationally, but certainly, at the Hopkins and other hospitals. And, there's an element of anger about all kinds of things, work schedules and you name it. And, very seriously, just recently at Jefferson in Philadelphia, someone came in and, with a weapon and harmed another employee to, kind of thing. So, and, if there's all kinds of relationship issues, we've certainly had those here at Hopkins. And, again, it's called speaking up. If you feel uncomfortable or if you know of a situation, and it's not getting people in trouble, but I mean, we need to protect staff and patients from each other and, across the board. Certainly we have a couple areas where our trauma patients and our gunshot patients come in, and we always are afraid of something happening with, a gang member or something like that. And Lisa, you mentioned the other day when we had a pre-meet about the fact that you're going to have some special precautions put in place for family members coming in, like turnstiles and so on. And that I know is a recommendation from when we had a security review. And I know that nurses and clinicians, in the floors are like, yeah, they can just walk in Zayat, or they can walk in here, or they can walk in there. I mean, we've gotten a little better at, especially because we don't have people coming in COVID, but I really think the early reporting, we also need to see what areas, we can't send all the complicated patients to, whatever, Meyer 1 or whatever the floor might be. And I think, having a good assessment across the board would be a really good way of, of having, and making sure that leadership's aware. Going up the chain of command. I like the executive, response team. And the more they're aware is the more that they can put resources into helping us, helping you all as clinicians with this really challenging situation.
Yeah, thank you, Meg. So I'm wondering if any of our participants have specific questions that you would like our panel to address. These are challenging times that we're in, and I think sometimes it's easy to just sort of see this as an operational issue, when in fact underneath it are really important ethical values of respect for everyone, and how we create safe and working environments where people can come to work and to do what they're trained to do, but also so that patients and their family members can have the benefit of our expertise and our caring and compassion as well. And so this balance is one that I think we're commonly, sort of struggling with. I'm wondering, Stephanie, any other comments that you have related to the case, related to your experience, any other insights that you'd like to share? It says, here's a question for you, it looks like. With the involvement of so many services to help navigate the situation, how did you keep your staff up to date on action items, decision-making, et cetera? So a sort of real practical question from Ashley about, so.
I often send out a weekly updates to our unit. So if it was pertinent to a change in practice, like the list or something, then I would have sent that out to our staff to let them know. Especially when the security got involved, because security was there 24/7. So they were always with the patient. So that day I sent out an email, made sure staff was aware. But I will say from your original question was that once I did voice this concern, which like you said, I may have been a little bit later than probably should have been, but I do feel like we got amazing support from the hospital. So from all the different places, from the executive teams and getting all of that, we did get a lot of support for our staff. I mean, it was hard for our staff and we struggled for many months until he was here for almost 8 months. So for a long time they were struggling. So knowing that we were giving them that support, I think helped alleviate some of that. So I appreciate all the help that we got during that whole process, because this was a very difficult situation from a lot of different angles.
Yeah, and I know, Stephanie, that there's a way that a lot of times we feel kind of helpless because this is not a situation you can actually fix. And so, it's sort of, in a way, a cry for help when people reach that point where they are able to acknowledge that we can't really do this on our own. And even though we couldn't fix it per se, it does matter that we feel like we're all in it together somehow, right? That we have a moral community of shared responsibility and commitment. So, I think that's what we all hope happens, in these situations. So Meg, there's a question here about what's the argument against felony charges regarding violence against healthcare workers? Can you offer any insight on that, Meg?
Honestly, I can't. It makes no sense to me. I mean, we have fought. It's, trying to say that, it's a safe environment for patients, kind of thing, and a patient rights over, the staff rights kind of thing. But the American Nurses Association has been fighting for it, as has others. So it's, I don't know. I got to plug my phone in. My battery's about to die.
Yeah, Lynn, I'm not, I don't know the answer either, but it's a good question for sure.
Never can I understand it. And we have fought and we have really worked hard, but we need more people in Annapolis.
Yeah. Yeah. So I wanted to, before we end, I wanted to share some work that is happening at the Barrel Institute that I think may help us bridge this gap that feels like sometimes it's either or, patient experience or it's staff safety. But one of the initiatives at the Barrel Institute is really to shift from focusing on either or to and to acknowledge that the human experience in healthcare encompasses both the patient, the workforce, the community, and it's not a move away from our traditional focus on patients, but rather the positive and natural expansion of that commitment. And so one of the things that has happened at the Barrel Institute is the creation of a pledge to transform the human experience, which includes everyone, to really reframe our commitment, first of all, to be aware of and dismantle some of the systemic contributions to racism and prejudice, and to enlarge our vision for how to provide patient-centered care is to understand and include in that understanding the needs and vulnerabilities of the healthcare workforce as a way to honor their commitment, their inherent dignity, and their purpose. Because I know as a nurse myself, the reason we're here is to serve our patients. And when we are in situations where we feel that our ability to do that is threatened or violated in some way, it really does begin to erode our sense of identity and our sense of integrity. So the Barrel Institute pledge is really about seeing this whole constellation of commitments to recognize and maintain our focus on patients and families, but also to include in that a commitment to the well-being of clinicians, as well as a means for us to accomplish that important goal. So I just wanted to share that with you, and for us to have a moment to think about how we can continue this conversation in a way that actually is respectful. And so I'm going to ask our panelists, and I'm going to start with Lisa this time. What is your hope in terms of being able to move forward with maybe that shift in thinking to a more inclusive of all of our ecosystem of people who are providing care?
Well, I really liked your 7 ethical statements, as well as, I do work with the Barrel Institute as well. And I really feel that this is absolutely moving in the right direction. And I think that it is, for me, it's really thinking about this partnership, the partnership between the healthcare team and the patient and their loved one. And we've changed the word visitor to a care partner. And I expect that people should behave as care partners in this. So that is my hope. And obviously through COVID, it's been really tough, and we've disconnected people from the healthcare team. And I think it's made it incredibly challenging, and we need to get back to that partnership so that we're working together for healing. And so that's my hope.
Great. Thank you. Stephanie, what's your hope?
I mean, I agree. I just hope that staff or nurses or anyone that comes in any sort of situation like this just knows that it's safe to speak up, ask for help. I think de-escalation training would be very helpful if more staff could get that, because it is more apparent that this is happening more often than it used to, because I think people are just irritable. It's a lot going on in the world. It's stressful. Everything's stressful. Everyone's stressed. So I think that kind of training would really be a hopeful thing for staff to be able to know how to de-escalate and still feel safe in those unsafe situations.
Thank you. And Meg.
I agree with everything that's been said. It's called RESPECT on all sides. And I think that, setting the stage early with someone, being in a hospital, and I've been a care partner and everything else, being in a hospital is scary. And, there's some nice people and some not so nice people from care side as well. So I think really setting expectations early about how people communicate. And I'm not just talking how the patient communicates, but also the caregivers. And I certainly understand the stress levels related to the non-compliant patient. I was a psych nurse, and that's probably how I became a lawyer. Somehow I got my head hit or something. But, I think that, it used to only be psych. It used to be the ER. Now it's everywhere, be it OB, NICU, you name it. And I just, my heart goes out to all the care providers. I certainly was in your world. But I also, think that we need to start from day one. And I really do like in the patient's rights and responsibilities, we put, that requirement that patients have to behave as well, and their family members. We put that in years ago. And we were probably one of the first around the country because people didn't want to raise that issue. So, but I just, all get along. That's all we want. We want it for the world. We want it for Hopkins.
Great. Thank you, Meg. So, as you're thinking about this topic and the ethical dimensions of it, there are many opportunities for us to be more proactive, to know that you're not alone and that there are resources that are available. There are resources to, raise the issue up the chain of command. There are resources to deal with the emotional responses. And there are resources to help us try to navigate these different perspectives and to use them in a more proactive way. I think the bottom line is that we all want to do our best in our workplace. And so having, a sense of how to even talk about and describe the tensions that we're experiencing in some of these cases can sometimes be helpful in trying to illuminate a path forward. So I want to thank our panel today. I know this is an issue that the Johns Hopkins Health System, Lori Payne and Deb Baker have been very much attuned to and are really working hard to try to find a path for making more resources available and creating the kind of environment where everyone can thrive. So I want to thank our panelists today for participating. I want to thank our participants for being part of this. And we look forward to having you be with us again for our next Ethics for Lunch, which next month is April, which is our Schallenberger lecture. And we are very excited to be able to provide that for you again, and look forward to your participation. So stay tuned. You'll be seeing an announcement of that particular lecture in honor of our dear Clyde Schellenberger, who was our chaplain at Hopkins for decades. So great to see all of you, and thank you again for showing up today.